Okay, here we are back with part 4 of chapter 27 in infectious diseases. We're going to go through, in this part, we're going to go through a lot, kind of like part 3. We're going to go through quite a few infectious diseases and viruses and those kinds of things that people can be exposed to. Most of these, you need to think of these on a global scale and not just, the state of Oklahoma or the country of the United States. They're a little more globally. And I'll drill down, I might drill down and spend a little bit more time on some of those that we might expect to see, here in the States. Whereas those that are less likely to see here in the States, I'll probably just kind of skim through those a little bit faster. At least I'll try to. And I'll spend a little bit more, at least maybe speak into a little bit more of the ones that we might expect to see, that are a little more commonplace here locally. Speaking of, this one here is the Zika virus. There are a few cases that happen here in the States, but most of the cases here in the United States are travelers that are returning from somewhere else where this virus is common. This is mainly spread through bites from infected mosquitoes. A major concern is that an infected mother can pass this virus on to their baby during pregnancy, which can cause some very serious birth defects like microencephaly, swallowing issues, and even learning delays. Zika can also be transmitted through sex, and typically it's an infected male that winds up giving it to his partner. This is a very important public health consideration because it can be spread that way. So once it's kind of established a foothold, it can be spread from person to person, absent an infected mosquito. A Zika infection has been linked to a higher risk of Guillain-Barré syndrome, which is, recall that's that rare autoimmune disorder that affects nerves. The incubation period for this virus usually ranges somewhere between 3 and 14 days. And of course, Zika can be found in urine, saliva, semen, and other places, which suggests that it can be spread by more than one vector. It can be spread by more than just mosquito bites. We can actually spread it from person to person if we're not careful. Many people infected with Zika don't experience any symptoms at all. And when the symptoms are present, they often include things like fever, rash, joint pain, muscle aches, headaches, and red eyes without any kind of drainage like we might see with pink eye. Because the virus is most common in certain regions, it's important to ask about recent travel to areas where Zika is known to circulate. Of course, management's mainly going to be supportive. We're going to focus on taking care of those symptoms like fever and pain. If there is a skin or a wound that is exposed, make sure to wash that area with soap and water thoroughly. And for exposures involving the eyes, nose, and mouth, be sure to flush that area with plenty of clean water to, reduce the risk of contracting Zika. Always follow standard precautions to prevent infection. Anytime there's a splash concern, you need to make sure you're wearing gown, goggles, and all that kind of stuff. If you experience a sharps injury, report that to the designated infection control officer immediately, and then you're just going to follow your agency's policies on how to manage that from there on. Now, Lyme disease, this is a very common tick-borne disease, and we see a lot of these in the United States. It's spread by the deer tick, which carries this bacteria that is known to cause Lyme disease, and the name of the bacteria is not really important, but it does cause Lyme disease, and it is a bacteria, so it can be typically treated with antibiotics. Cases are most common in the Northeast, with peak transmission occurring from June to August, so in those summer months when everybody's outside and active. Lyme disease tends to have a greater effect on children under 10 and middle-aged adults more so than any other age groups. It isn't spread from person to person, so it's only spread by ticks, so you're not going to catch it from somebody else. And of course, the incubation period for this has got a really broad range. It can be anywhere from 3 to 32 days after the tick bite. So they could still find the tick attached, and the tick could be long gone before the symptoms begin to show up. Lyme disease can affect the skin, heart, joints, nervous system, And then some people may not even have any symptoms at all. So it can depend and vary widely. When the symptoms do show up, they typically develop in 3 stages. The first, you kind of have that hallmark bullseye rash, which often appears at the bite site. And this is usually, oftentimes we find these in the groin, thighs, or armpits, and that's just because the tick tries to find that place where it feels like it can kind of hide and be protected and not be discovered. Additional skin rashes may appear as the infection spreads, and people often will develop some flu-like symptoms such as fatigue, chills, and muscle aches. Other possible symptoms might include a productive cough, swollen testicles, sore throat, enlarged lymph nodes and spleen. If untreated, neurological issues like meningoencephalitis or nerve pain can develop within weeks, along with heart problems such as pericarditis, myocarditis, and even abnormal heart rhythms. Late manifestations, if this really progresses and left untreated, the most common issue is going to be arthritis, especially in the large joints. Long-term neurological symptoms can include memory problems, low mood, and severe fatigue. So if untreated, Lyme disease can get ugly in a hurry. However, if it's treated, it can be managed pretty well. So ideally, what we want to do is prevent tick bites, but that's not always possible. So, however, they recommend wearing long sleeve shirts, long sleeve pants, and using insect repellent when spending time in areas where ticks are common. In Oklahoma, if you're wearing long sleeve pants and long sleeve shirts, you're going to melt from the heat. So it's not always ideal. So insect repellent is a good alternative. If a tick is found, remove it promptly and correctly. Of course, you're gonna use some tweezers to grab a hold of that thing as close to the skin as you can and pull it straight out. Don't do the twisting or turning or anything. You just want to pull it straight out quickly. And of course, please be sure to clean the bite area thoroughly afterwards to keep any kind of other infection from setting up. Routine antibiotics aren't usually given after a tick bite, so we don't, just because you got a tick bite doesn't mean you need antibiotics. Instead, if a medical evaluation is needed, then you're going to kind of make a judgment call based on the particular situation that you're in. Another tick-borne disease that's pretty common, and it's an ugly one. It's the Rocky Mountain spotted fever, and it's also transmitted through the bite of ticks that are infected with a different bacteria. It's a Rickettsia bacteria. Key ticks are the ones that spread the disease, and these include the American dog tick, the Rocky Mountain wood tick, and the brown dog tick. So these are the ones that your dogs can carry. Rocky Mountain spotted fever can progress quickly and become severe or even fatal if not treated with the right antibiotics within the first few days. Early recognition and treatment is essential for a positive outcome. When assessing a patient, look for symptoms like fever, headache, abdominal pain, vomiting, muscle aches, and the possibility of a rash. The initial diagnosis will be based on the clinical signs and symptoms that the patient is presenting with, as well as their medical history. To confirm the diagnosis, lab tests are usually needed for a definitive result. The first thing that we're going to do, the first line of treatment for these patients is actually going to be doxycycline. It's an antibiotic that's used to treat Rocky Mountain spotted fever. It's actually most effective when started within the first 5 days after the symptoms begin. And it's important to note that Rocky Mountain spotted fever is not contagious. It is one of those things, like I said, it's a bacteria, but it's not an infectious or a contagious bacteria, meaning you can't catch it from somebody else. You're almost going to have to get bit by the tick in order to get it. Hantavirus has been getting a little bit more publicity lately, and you would think this wouldn't be something that is found much in the United States, but it is. Every year, places in Arizona see cases of hantavirus show up. This is also known as the hemorrhagic fever with pulmonary syndrome. Hanta is most commonly associated with rodents like deer mouse, white-footed mouse, or the cotton rat. Early symptoms are flu-like, but they can quickly progress to severe, and even life-threatening breathing problems can result as well if it's allowed to progress. So the virus is actually found in the urine and feces as well as the saliva of these infected rodents. Transmission typically happens through direct contact with rodent waste. The most common route is through the aerosolized inhalation. So while direct contact with waste is the typical route, it can be that you're in an area that has so much urine and feces in it, rodent urine and feces, that it can be inhaled. Often this happens while someone is cleaning those infested areas where the rodents have been. So it's important for people to take precautions in that, especially if they live in those regions where these particular rodents exist and where there's been recent outbreaks of the hantavirus. Incubation period is 12 to 16 days, but it can range from as short as 5 days to as long as 42 days following exposure. And of course, with this one, like the previous two that have been mentioned, there is no human-to-human transmission possible with the hantavirus. Signs and symptoms are going to include a sudden onset of fever that lasts from 3 to 8 days. And then there's going to be a headache, abdominal pain, loss of appetite, and vomiting. Now remember, there could be some respiratory symptoms that come into play with this one as well, so be alert for those. When that pulmonary syndrome kind of shows up, some signs and symptoms that we might notice in this second stage would be, or it actually is 2 stages, I'm sorry. First stage would be the fever, chills, headaches, vomiting, diarrhea, and abdominal pain. Stage 2 is where that cough would show up, shortness of breath, fluid accumulation in the lungs, and even low blood pressure. Cardiac insufficiency would begin to develop in these as well. Always follow standard precautions. If we suspect there is that this is a hantavirus, we want to make sure that we're protecting ourselves because it is still possible that they're in a contaminated environment that could be problematic for the rescuers. Routine cleaning of the vehicle, of course, is going to be important so we can prevent further contamination. And of course, supportive care may be necessary for things like assisting respirations, providing oxygen therapy, watching for a cardiopulmonary collapse, and those kinds of things are going to be important. Rapid transport to a medical facility is going to be crucial for these patients so they can begin the treatment process. Rabies, yet another one pretty common to us. It's found worldwide, though cases in the U.S. have decreased significantly since the 40s thanks to control programs that we use for vaccinating domesticated animals. However, there's a lot of non-domesticated animals like skunks and those kinds of things that still carry rabies. So it is still out there. It is still possible in the United States. The primary mode of transmission for this is through a direct bite from an infected animal. Basically, mixing saliva or blood, with our blood, with human blood, is going to result in a transmission of it. Common carriers are going to include raccoons, skunks, foxes, coyotes, and bats. They're very common for carrying this. So anytime someone has been bitten by one of these, or a dog or cat that is unknown, that has an unknown vaccination status that cannot be proved that they haven't had the rabies vaccine, we should suspect that this could be what's going on. Other transmission routes are pretty rare, but they can include contamination of mucous membranes like the eyes, nose, and mouth through aerosolized exposure, or organ transplants. So realize that someone can actually have rabies and do an organ transplant and move that over, because rabies is not something that's commonly tested for in donated organs and blood. Non-bite exposures are very uncommon in human-to-human transmission, but has not been really well documented. So while it's not common, it's probably still possible. The incubation period for rabies ranges from 2 to 8 weeks, so it's a slow developer, and sometimes you may not know. So preventative treatment may be taking place before there's even any indication of symptoms. So bear that in mind, that they may go ahead and start preventative treatment until they have a definite answer on the status of whoever the biter was. So we'll look for some other non-specific signs that we might see initially with rabies. Might be fever, chills, sore throat, headache, weakness, those kinds of things. When it enters the neurological phase after they've had this for a bit, then we're going to see some maybe some hyperactivity, seizures, bizarre behavior, and then hydrophobia, where they kind of have a fear of water. And this is that phase where we see the classic thing of this animal that's foaming at the mouth and they're behaving crazy and all that stuff. Part of that is because of the fever, and then the other part of it is the neurological damage that's happening. It kind of sends them into a delirium state. Same thing happens with humans. As this disease continues to advance, we might see paralysis and significant mental status deterioration. There have actually been recent cases of survival even after the symptoms have started, so it is possible to come back from this. However, it would be a case-by-case basis of what the long-term damage might be from this. So ideally, early identification and early treatment is essential, because the longer this goes and the more symptoms that begin to show up, the survivability starts to decline. Standard precautions for patient care and your vehicle cleaning are going to apply with these. So if you are bitten or scratched by a potentially rabid animal or human, which is possible, the rabies vaccine may be offered if indicated. So they may say, hey, go ahead and take this vaccine, which will provide some protection. And there may be other courses of treatment that may be required as well. As a general rule, the CDC does not recommend routine rabies vaccinations for EMS personnel. So if you find yourself potentially exposed to rabies, you probably will be directed to get that vaccine. The Middle East Respiratory Syndrome, or MERS, is a viral disease that poses very low risk in the U.S. to healthcare providers and the general public. The cause of agent is the MERS or MERS, or it's a coronavirus. It's similar to the COVID, so it's a coronavirus, so it has some similar properties. And this particular one causes some respiratory illness, and the transmission's usually going to occur through close contact with an infected person, particularly in healthcare settings. This is less commonly seen in the United States. However, with global travel, it is entirely possible that there may become a pocket of it that begins to spread a little bit. Incubation is 5 to 6 days, but it can take as long as 14 days for the virus to kind of take hold. Of course, getting a detailed travel history is going to be helpful with this. But realize, even though you have a detailed travel history, it's not going to necessarily mean that you know exactly what viral thing that you're dealing with is. So getting a travel history, knowing that region, and the CDC and the World Health Organization, they'll have information of what the things that it might be based on that region or that particular place that they visited. Key symptoms are going to include fever, cough, shortness of breath, very similar to a lot of other things that we see. This one will have a little bit more prominent gastrointestinal issues like nausea and vomiting along with it. So that's going to be a little bit different from some of them that we've just mentioned. Be ready to provide ventilatory support for patients who may develop acute respiratory distress syndrome, because it is not unheard of with these patients to really have really bad respiratory issues. There's really no specific antiviral treatment for this particular one, for this Middle Eastern respiratory syndrome, Medical care is going to focus on managing and alleviating symptoms. Healthcare providers should follow those standard contact and airborne precautions like we do with some of them that we mentioned in the very first section. You know, putting a mask on your patient and maybe an N95 on yourself. If you're exposed, if you're certain of an exposure, of course, notify your infection control officer immediately so they can take the correct action to make sure that not only are you treated, but you don't continue to spread that if there's a concern that you might. Of course, tetanus is a lot more common in the agricultural and underdeveloped areas where contact with animals and animal waste is more likely. And of course, those immunization rates are low, so there is an immunization against tetanus. It is absolutely preventable with the vaccine. This immunization has been around for a long time. The tetanus is basically a bacteria that's found in the intestines of horses and other animals like cattle and that kind of thing. So that's why it's pretty common in the agricultural industry. Some cases are actually, ironically enough, linked to IV drug use as well. So it's not exclusive to animals. Transmission occurs when the tetanus spores enter the body through a puncture wound with a puncture wound of some contaminated object that's been exposed to animal feces or soil, you know, that kind of thing that may have this particular bacteria in it. It can actually be spread through contaminated street drugs, as I'd kind of mentioned, through IV drug use. Tetanus is not transmitted from person to person, so we don't have to worry about that. Incubation time is about 14 days, but it can actually be a lot shorter, as short as 3 days, but average is about 14. So when we're checking these patients out, start by assessing the wound site for any signs of infection. They may have painful muscle contractions or rigidity, and that's where the tetanus side of it comes in, the tetany part of that. The rigidity may follow those muscle contractions. And these often start in the face, jaw, or the trunk muscles. Used to be called lockjaw. Tetanus used to be called lockjaw because it would lock up the muscles of the jaw. And these are kind of some of the early signs that we'll see with this, and it's a pretty good indication that we need to be looking for a wound site, you know, where maybe there was that exposure or that it was maybe drug related. A key sign of tetanus is abdominal rigidity as well. Those abdominal muscles will contract. Other signs, of course, they're going to have difficulty swallowing. They may even have some hydrophobia, which is similar to what we see, in patients that with rabies, drooling, and respiratory distress. This one can be sometimes confused with rabies. So make sure you do your history on these, and it's going to be the muscle contractions, rigidity, and the abdominal rigidity that's going to be a big clue that you're, and actually a wound site that's not a bite, that is more of a puncture wound or something like that, or drug use, that's going to lead you down the path of tetanus versus rabies. Always wear gloves when treating wounds and managing the drainage. The patient may need some airway support and ventilatory support. Provide oxygen and IV fluids may also be, providing oxygen and IV fluids could also be necessary. For treatment of this, there is an immunoglobulin, a tetanus immunoglobulin that is available for treatment, and this is going to be how this is going to be treated. Basically, what we're going to do is we're going to add some antibodies in there that's going to try to, eradicate the tetanus bacteria. Paramedics should receive a tetanus booster every 10 years for continued protection, especially considered some of the residents and homes and the places that we're exposed to, because tetanus can still live in other places, dirty, unkept places that, that we oftentimes find ourselves in. So a person can actually get infected with antibiotic-resistant organisms as well. And this happens due to the overuse or misuse of antibiotics. And this plays a role in the development of antibiotic-resistant microbes. It's critically important for EMS to use antibiotics carefully and as indicated. And we should promote this with our patients and the people that we come across to make sure that people complete the entire prescription of antibiotics whenever they're administered to them. Of course, the overuse of antibiotics also plays a significant role in the antibiotic-resistant bacteria, and this is especially true in the healthcare settings. So this particular one, this methicillin-resistant Staphylococcus aureus, this is one that we see quite often spreading around through the hospitals, and we refer to this one as MRSA. MRSA became resistant to penicillin in the late 50s, which was really the first clue that we might have a problem with this. And then methicillin, of course, first it was penicillin, then it was methicillin resistance emerged in the 60s. This particular Staphylococcus it's a particularly viral one where that it mutates and changes. By the 70s, MRSA was widespread in U.S. hospitals and has since spread into the community. So it's started in the 50s. In the 60s, it got worse. In the 70s, it got a lot worse. Now we find it in the hospitals and now into the communities. Healthcare-associated MRSA cases have been on the decline due to improved infection control practices. So we can keep this MRSA at bay if we use the right cleaning and disinfection practices and infection control practices. And that's why a lot of the things are in place for how we decontaminate our equipment in our vehicles. However, these newer MRSA strains out there have been beginning to show resistance to other antibiotics. This is a very virulent bacteria that we deal with. So vancomycin is generally effective against MRSA, but some resistance to vancomycin is beginning to emerge. There's some other treatment options of antibiotics that are out there that can be used to treat this. Some other antibiotics, they're always developing new ones. So MRSA is primarily spread through patient-to-patient, excuse me, patient-to-patient through unwashed hands of healthcare providers. So how it gets from place to place is us. We're the ones that are responsible for spreading it to other patients, and that's why it's really common in healthcare facilities. Studies show a high carriage rate of Staphylococcus in the nose, with smaller but significant MRSA carriage rates as well. So this Staphylococcus and MRSA Staphylococcus can actually survive in the nose of people, and it's estimated that people touch their face, mouth, and nose somewhere in the range of 2,000 to 3,000 times a day. And this is why healthcare providers can easily spread this. The pathogen enters the body through breaks in the skin, and then it begins to set up shop. Risk factors are for patients that are undergoing antibiotic therapy, prolonged hospital stays, stays in intensive care and burn units, anytime there's exposure to an already infected patient, and those patients living in long-term care facilities are at much greater risk. So patients may carry MRSA without any kind of symptoms, or they may be actively infected. So the incubation period is typically between 5 and 45 days. So this one can be a wide range of an incubation period because they may be carrying it for a long time before it actually converts to a true infection. The communicable period varies depending on the type of infection that it is. And of course, the potential manifestations of infections are typically have to do with those skin abscesses and cellulitis, and of course maybe infections of the pleural spaces and pleural linings. So this is where these things can kind of show up, and they can lead to full-blown sepsis. Secondary infections can develop after there's been a bloodstream infection as well. This is a particularly nasty one. We often think of MRSA as being something that is living in a wound on the skin. However, it can be much deeper than that. It can spread to other areas inside the body. For soft tissue infections, typically they're going to incise and drain that particular wound. Of course, antibiotics may not always be necessary, and those will be managed on a case-by-case basis, so they may or may not get antibiotics. Always use standard precautions with these patients. And if you're exposed, make sure that you notify your infection control officer and follow whatever post-exposure treatment they recommend, but it's generally not necessary unless there's true signs and symptoms of MRSA setting up shop. Then we have vancomycin resistant. We mentioned this one just a little bit in the MRSA ones. This is the Versa. It's the primary drug used to treat Staphylococcus infections. This is similar to MRSA. However, these infections can usually show up as pimples, boils, or other things on the skin. And infections can become severe and wind up leading to sepsis. These infections, fortunately for us, but we live in a global community, fortunately for us, these infections are pretty rare in the United States. But as I just mentioned, we live in a global community, so it is possible that these things might start to show up, among our communities. So risk factors, those at highest risk for this are those with underlying health conditions, those that have a history of MRSA infections, those with indwelling catheters, patients that have been recently hospitalized, and of course, patients with a recent exposure to vancomycin or other antimicrobial agents puts them at higher risk, which is ironic. Assessment, of course, signs and symptoms that we might see with this are localized skin abscesses, cellulitis, pneumonia, bloodstream infections, meningitis, osteomyelitis or a bone infection, fever, chills, body aches, weakness, cold, chest pain, trouble breathing. Again, with many of these things that we deal with, it's not going to be absolutely critical that we're able to go, aha, this is Versa, or this is MRSA, or this is some other infectious disease or illness. We're going to treat these things essentially the same way. It's important to recognize that this could be something that we can spread from patient to patient, so we should always take the highest level of precautions. Of course, Versa is treatable with the proper antibiotics. Again, using those standard precautions and using those contact precautions anytime that we suspect that there's something out of the norm going on or something that we could spread from patient to patient, or especially ourselves, we should take those precautions. Routine cleaning, our regular cleaning of our equipment and the truck is going to work. And of course, doing our regular hand washing as we should will work as well. So taking those standard precautions is going to protect us from not only ourselves from contracting MRSA and Versa and these other things that we've been talking about over these last 3 or 4 sections of chapter 27. Taking those precautions, it's going to protect us from all of those by taking just the standard precautions. Of course, always ensure that any open cuts or wounds that you have are covered and properly protected. And then if you're exposed, if you suspect an exposure, reach out to your exposure control officer. But like MRSA, post-exposure treatment is generally not recommended for these unless you start to develop signs and symptoms of it. So just protect yourself, and you're going to be fine. And then there's this VRE, this vancomycin resistant intercocculi, however you say that, I don't know. This is a normal organism found in the GI, urinary, and genitourinary tracts. It can grow in both reduced oxygen and oxygenated environments, so it's a pretty tough little thing, and it stays alive pretty well. It actually remains one of the top 3 causes of healthcare associated infections in the U.S. So odd that if you haven't heard about it, the VRE is very, very common. It's primarily a healthcare associated infection, so it's up to us to try to prevent and take care of it and prevent spreading it. Individuals are usually only at risk if they are already ill or if they're immunocompromised. ICU patients, transplant patient recipients are particularly vulnerable. VRE is commonly found in urinary tract infections and bloodstream infections. It can survive on surfaces for extended periods of time, and transmission can actually occur through direct contact with contaminated surfaces. So it's a little easier to get than you think. Only infected patients can transmit VRE, so if you're not infected, you're not going to transmit it to somebody else. VRE infections can be treated with some of the newer antibiotics that are out there. So it's not the end of the world. It is treatable. However, we don't know how long it's going to be treatable with that particular antibiotic before it becomes resistant to that. VRE can cause urinary tract infections. In fact, it's one of the more common things we find with those. So catheters can serve as an entry point for these infections. And of course, it can lead to bloodstream infections, which may progress into full-blown sepsis. Surgical wounds are also very vulnerable to VRE infections as well. So use standard precautions and our contact precautions. Wear gloves and practice diligent hand washing anytime you suspect that you have come across a VRE patient. A gown is necessary to make sure you protect your uniform from coming in contact with wound drainage or anything like that. So if there is that risk, make sure you're using a gown. Thoroughly clean all areas of the ambulance that had any contact with the patient, as well as any equipment. But the routine procedures that we do are typically sufficient for keeping this particular bug at bay. If you have direct contact with an open wound or body fluid from an infected patient, of course, notify your infection control officer. And prophylactic post-exposure treatment is usually not indicated. As mentioned with the previous two, only if you start to show signs and symptoms of an infection will they begin to treat you with those highly valuable antibiotics. They're not going to do it blanketly because they do not want this to become resistant to the newest antibiotics. Okay? C. diff, another very common one that we spread throughout the medical community. It's not really considered a multi-drug resistant organism, but it's often managed in a similar way because we don't want it to become resistant to those treatments that are actually working for it. C. diff is an infection that can occur after antibiotic treatment disrupts the normal balance of gut bacteria, allowing this C. diff bacteria to proliferate. This is a spore-forming bacteria that produces two endotoxins that lead to really, really watery diarrhea. So that's the main sign and symptom we're going to see this. They're going to have taken antibiotics recently and they have really watery diarrhea. The infection is transmitted through contact with surfaces contaminated with feces, so poor hand washing and all that kind of stuff after going to the bathroom is how this can be spread. It can also be spread with the unwashed hands of healthcare providers, so we can actually spread it as well, not just the patient. In many cases, the infection resolves itself in 2 or 3 days after discontinuing the antibiotics that caused it, so it's not really, really hard to treat. But the symptoms that we see with this are these frequent watery, green, foul-smelling diarrhea. Nausea and vomiting can be in there as well. Fever, loss of appetite, and the abdominal discomfort from everything kind of moving so fast through the system. There are some other diseases associated with C. diff infection. It can lead to sepsis, can wind up with colonic perforations. And there is some pseudomembranous colitis that is associated with the C. diff infection. So obviously, if there's already some colon issues going on, C. diff's not going to make those things any better. In fact, it can kind of make things worse. Always use gloves. Practice thorough hand washing with these patients, especially knowing that is the number one route for this to get spread is through poor hand washing. Make sure you wash your hands. Clean all those contaminated surface with a chlorine-based solution that'll kill that C. diff off. If there is contamination of open skin areas, be sure to report that. And of course, medical follow-up is typically not required, but as long as you report that, and they'll give you direction or advice on what to watch out for. CRE, this is a bacteria that is highly resistant to most antibiotics, making it really, really difficult to treat. They believe it was likely introduced into the United States through medical tourism, which people travel to different parts of the world to get treatments and then return back to the United States. This particular bacteria has I think it's a bacteria. Yes, it's a bacteria. This particular bacteria has a very high mortality rate, often up around about 40%. We have this Enterobacteria, I can't even say that word, that are typically found in the GI and vaginal tracts. And this can actually spread through unwashed hands and on contaminated surfaces, much like C. diff. However, unlike C. diff, CRE is not spore forming, which influences the choice of cleaning and hand washing products that we want to use. So we're going to use something a little different with CRE to make sure that we keep from spreading it. Symptoms can vary depending on the location of the infection in the body. Patients may present with fever, urinary tract infection, symptoms of fatigue, chills, and early signs of sepsis. Ask about any over-the-counter medications that they've used for open sores, such as topical antibiotics and whatnot, as well as a good history of any long-term antibiotic treatment that they may be undergoing or recently undergone. Follow the standard precautions for contact precautions. If there are any draining or open wounds, that kind of stuff, just follow that. Make sure you protect yourself and protect your clothing. Soap and water, thoroughly washing your hands, and of course clean your equipment and your vehicles with a chlorine-based solution for this particular one, or one that is particularly made or specifically made for treating the CRE. SARS, this is a severe acute respiratory syndrome, resulted from a combination of two viruses, of course, go figure, from mammals and one from birds. So we're just getting these little viruses coming from all these animals all over the place. And of course, the virus was identified in bats, actually in Hong Kong. So we're seeing a lot of these coming from these Middle Eastern countries. And a lot of these, it's believed, and don't quote me on this as being absolute, but a lot of these are believed to come from those wet markets where they have processed meat and foods like that kind of in an open air market, and that those kind of comes in through those, and maybe that those meats, when they're being consumed, are not thoroughly cooked and cleaned properly. So that's just a part of the theory. It may actually not be true, because we know with COVID that actually came from a lab, over there, that they were experimenting on things. So this could be the same with SARS. SARS is spread through close personal contact with an infected person. So probably more along the lines of droplets and that kind of stuff. The typical incubation period is about 10 days from exposure. The exact communicable period is not definitely established. SARS kind of showed up, I want to say, probably roughly about 25 years ago, and we've seen it a lot in the Asian countries, and we would see images of them walking around wearing face masks and all that, much like everybody in the world was wearing during COVID, 5 years ago. So that's kind of when SARS showed up, and it caused quite a scare. Signs and symptoms are fever greater than 100, headache, body aches. After about 7 days, a dry cough may develop, and in severe cases, it may result in pneumonia, and the patients may actually need some respiratory support. So on the surface, we may not be able to distinguish between SARS and COVID, because they do look very similar, and can result in some similar symptoms, as what might we see with flu symptoms or other symptoms. So realize we're dealing with a virus that can be passed on from person to person. So we want to make sure that we use the protective equipment to minimize our own risk. And that's going to be gowns and masks, and those, depending on the situation, if there's a lot of coughing and that kind of stuff, eye protection. Notify your infection control officer, after you've taken care of a patient if you suspect SARS. This is one of the big ones that they really control. Much more so than even COVID these days. They want to know about SARS. And it may require up to a 10-day quarantine if you're exposed to this. Unlike COVID, there's not a vaccine for it. And treatment's going to be generally supportive when taking care of these. Avian flu is another one, the bird flu. The first cases were reported in Hong Kong, yet again in '97. The flu naturally occurs in bird populations and is carried in the intestinal tract of wild birds. It is highly contagious among domestic bird populations, and there's not really been a lot of evidence of rapid human-to-human transmission, but the overall risk of transmission to humans is relatively low, but it's low, not impossible. This flu has, kind of found its way around the globe and has spread to a lot of bird populations. This, among others, has resulted in the, global chicken populations being down as well. Always obtain that travel history to assess the potential threats of exposure. Signs and symptoms in a person would be fever, sore throat, cough, muscle aches, eye infections. Again, symptoms we might see in other things. Illness may progress to pneumonia or severe respiratory distress, so we need to be prepared to provide ventilatory support for these patients. Once again, it's not something we would necessarily know that they have, you have the avian flu. We're not going to be able to distinguish that, because even once we take them into the facilities, they're going to run tests to determine what it is that they may have. Of course, masking, surgical mask on the patient and ourselves to reduce transmission. Follow those current CDC recommendations for healthcare provider protection, which is going to be that N95 and that kind of stuff. Antiviral medication may be offered if it started within the first 48 hours of exposure, so there is some treatment for this. Of course, annual flu shot can help reduce the risk of the flu-related complications that might be associated with the avian flu. And of course, there also is, this is one of those few, that there is a vaccine available for the avian flu. All right, so that is the wonderful end of chapter 27. Yeah, there's a lot to that chapter, a lot of diseases, illnesses, viruses, and all that stuff that we get exposed to. These are nothing new. This is the same stuff that you guys that have been working out there as an EMT in the field, you've been getting exposed to many of these things, and life goes on like normal. So don't get a whole lot of anxiety over these. Just remember, our role is going to be primarily in the prevention of spread of these things. So you don't want to have a patient in your truck that has some viral illness and not be diligent about cleaning your truck afterwards and spreading that to a very vulnerable, 5-year-old that has had a recent organ transplant or something along those lines. So that's the goal in this. That's the purpose of this, is not to, give you 157 test questions over the specific viruses that we just discussed, but it's more so for you to know how to prevent the spread of all these by having an understanding of, kind of what makes them tick. All right, enough of chapter 27. We'll be back with chapter 28.